Okay, Dr. Jen Locke, thank you so much for taking time. I was thinking about this, thinking, oh man, it's too bad we have to record on a weekend, but it's a very rainy day here in Kelowna. So in some ways, we're kind of limited with how much we can do. But nonetheless, I appreciate you taking your time just to help build on a topic that I covered before in a previous episode about stress incontinence. And I picture, I mean, there's several, this is kind of women specific, this topic, or this episode, but, I kind of picture all of the women that are leaking when they cough, when they sneeze, when they lift something, when they exercise, and wondering, what are my options? And so in the previous episode, we talked a little bit about some of the first line defense treatment options that we as physiotherapists can offer. And I wanted to bring you on to talk about some of the other tools in your toolbox that you have as a urologist. So I wonder if before we get started, Jen, will you just start by introducing yourself to everybody so people know who you are?
Right. Thank you, Melissa. I'm very excited to be here again on your podcast. And I think, my expertise is in female urology. I'm a urologist. I was trained at UBC for residency, and then I went on to Toronto and did 2-year fellowship in reconstructive urology and female urology. So this is really near and dear to my heart. And I hope that I can share some insight into stress urinary incontinence in your patient population, because I'm hope that they can take some of this information and find something that works for them. So thanks again for having me.
Well, I've really appreciated having you in the community and the ability to be able to, send you the odd message every once in a while to kind of, can we work through this person together? Because obviously we both have a different skill set. And when Adrian and I talked on our last episode about what we have to offer as physiotherapists, we talked through the International Continence Society guidelines, just as that help direct our care and give an idea of how there's a bit of a flow that happens, or ideally a flow that happens when women are experiencing incontinence. And we talked about how generally there's an assessment that starts all that off, and looking at women and what's their pelvic floor function, what's their estrogen status, what kinds of symptoms do they have when they cough. They might do, their GP might do urinalysis, look at urine cultures, just to start to get a bit of a baseline and what's going on with this female. And then generally the recommendation would be to start with things like lifestyle and behavior interventions, pelvic floor muscle training, bladder retraining, all things that we look at as pelvic health physiotherapists. But there are so often times where, physiotherapy or hormone therapy or behavior modifications just aren't enough. And I always think of it very similar to if someone comes to see, goes to see their family doctor for a knee injury. Well, quite often they don't. They would go straight to a physiotherapist. But we would in our healthcare system, usually it would be go see a physiotherapist, and then we use all of our assessment and treatment tools, and then we kind of know when more is needed, and we'll send off, I think you might need a referral to the orthopedic surgeon or have some more imaging done. And so very similar in the women's health world, right? Where there's times where physiotherapy just isn't enough. And I'd love to talk to you a little bit more about what people can expect when they come to see you, or what's the flow look like when someone's referred to you.
Right. So, I'm a urologist, and there are gynecologists and urogynecologists that also are specialized in female stress urinary incontinence. And so when you come see any of us specialists after you've seen yourself as well as your family doctor, I think we have guidelines as to the way we work up the leakage. I think the most important aspect is actually getting to know each patient and knowing when the leakage happens, how bothersome it is in terms of the overall quality of life, and really differentiating between if the leakage happens with exercise, cough, sneeze, and or if it happens with urgency and frequency, because it really delves into a different treatment path once you've tried pelvic floor physiotherapy. That's because if you have stress urinary incontinence, it's often related to the urethra, which is the tube between the bladder and the outside of the body, not being strong enough to hold the urine in when you have a large pressure, such as a cough or sneeze or exercise. And so a lot of those are treated with surgical approaches, such as slings and those sorts of things. The other thing is, I think it's good to see us because maybe we give a refreshing look at the problem and look at other conservative measures that haven't been tried. Okay, so those conservative measures might be a continence, a pessary, especially for women that have pelvic organ prolapse at the same time, which is the sensation that the vagina is falling out. And another one is the impressa, or the urethral tampon, that can be used conservatively, specifically for women that are often exercising in leakage, and that's the only leakage they have. Sometimes that can be a good option. Did you want me to delve into more of the workup and
Yeah, exactly. I kind of picture I like to kind of flow through it in my head as far as like being able to help the client picture when they come to see you. Actually, right now, do you start most of your appointments with a telehealth appointment?
I think that now in 2022, I think that's exactly what's happening. I think the history is the most important part, and I think that's getting it over the telephone. And then, once the initial meeting happens over the telephone, whether or not there's other investigations, and you alluded to family doctor doing a urinalysis, making sure it's not an infection, but also there's some tests that we have, which are, one is called a cystoscopy. That's where a tiny telescope the size of a pen is put into the urethra, and we look around the bladder, and that's really to assess if the female is having a large amount of urine left in their bladder, and to really assess the leakage that happens when your bladder is full. And then another test we have in our toolbox is called urodynamics, and that's where you put two catheters in, one in the urethra, one in the rectum, and you can actually mimic the leakage that women have to see what it is that's going on. For example, if the leakage happens with urgency frequency as the bladder is filling, you know that that's more of an overactive bladder symptom, whereas you can see the leakage with cough and sneeze and the pressures that happens with this test. And so those are the two tests we don't always use urodynamics if it's straightforward, but definitely a lot of women end up having a cystoscopy. And so with that information, it really helps determine, number one, what type of leakage it is, but also how bad is the leakage, right? And that helps determine, for example, I think first line pelvic floor physiotherapy has a huge role in helping many women, but sometimes it's very, very severe stricture incontinence that we know right off the bat will not likely respond to pelvic floor physiotherapy. And we can see that on these tests.
So generally you would, at this time, just given what's going on with telehealth and how that's really emerging. So you would normally do a telehealth session, get a history, figure out what this person's symptoms are, and then decide what type of testing you need to do. For example, urodynamics, cystoscopy, or maybe have their family doctor do some more testing. And then you would have them, you would do a physical exam, I'm guessing, where you kind of look at the vulvar tissue. Yeah. Will you talk a little bit more about that, Jen? Like, what kinds of things are you looking for when you actually do a physical exam? Because you talked about prolapse, but what else? What other things are you looking at?
So that's a great question because everyone is different. And, some women get this leakage right after they've had childbirth and they're quite slim, and some women have obesity. And so if someone is obese, actually losing weight can also improve leakage on its own. So that's something we look at on physical exam. And the other thing is, if someone has had lots of abdominal surgeries, that will help us determine what type of surgery we would offer. And other things such as pelvic organ prolapse. So if the vagina is falling out, obviously, if that's also symptomatic, we would want to treat that at the same time as we're treating the leakage. And you alluded to the estrogen status. So lots of women that are menopausal start having leakage as well. And so sometimes that can be related just to genitourinary syndrome of menopause, which is sort of like atrophy of the vagina that happens as you age. And so sometimes even vaginal estrogen can be part of the treatment for the leakage and other symptoms that are associated with it. So those sorts of things are very important. The other two things that we look at on physical exam are is there any neurological deficits? Do they have good sensation in that area? Because that's important. Because do they actually feel like their bladder gets full, or feel like they empty their bladder? Those are the sorts of things we look at as well and work on. I think that a lot of those symptoms that go with stress incontinence are also treated very well with pelvic floor physiotherapy. And that's why I really encourage, especially with the wait times we have to see gynecologists, urologists, urogynecologists, it's very good to try and get the pelvic floor physiotherapy going, because it can address a lot of the symptoms associated with the stress incontinence as well as the stress incontinence.
Yeah, because actually what I'm seeing quite often in our community, which I think is great, is, whether someone is referred to a gynecologist or a urologist, that, that first appointment is often done by a telehealth, and they may or may not be started after they've been seen, whether they've had some sort of investigation or they've been started on estrogen, but it goes with I highly recommend you go see a pelvic health physiotherapist, because sometimes I know that these clients make it to you, they wait a while and they make it to you or a gynecologist before they make it to us. And so, I guess if we kind of think about that flow chart again, these people are being recommended, okay, let's go back to optimizing your tissue health. Let's make sure that your pelvic floor muscle strength is optimized, because no matter what we do, as far as treatment options go, this will be beneficial. And so I actually had a couple people off the top of my head that I thought were perfect examples. I had this one lady that came in, and I'll be honest with you, I don't remember right now if she came from her GP or if she came from a specialist, but she was leaking most of the day. She was saturating pads. And really, when we started talking about it, she was drinking way too much water. She was constipated. Someone had told her to drink more water, but she was drinking something like 9 full water bottles a day. And something as simple as just cutting down some education on the pelvic floor, but cutting down on water consumption. This person, I think, thought, this is so bad, I need to have a surgery. But just by changing some of the things that she did. I had another lady that was leaking all the time with exercise. It was very bothersome to her. I think a friend told her to come before she went to see a specialist, but she said, I'm willing to have a surgery. It was something as simple as talking to her about how she was skipping. It was when she was skipping and playing soccer. And we talked about what she was doing with her core muscles and her pelvic floor, and explained that she was squeezing those muscles the entire time she exercised. We talked about how that isn't efficient use of her muscles, and her leaking went away. Or for example, they've heard I should do more Kegels, but when you assess it on, physical exam or use ultrasound just to be able to show as biofeedback that they're actually doing a bearing down movement with their muscles and not actually recruiting those muscles how they think. So I guess just going to show that all of these women would have considered their symptoms very significant and put themselves in the I need surgery box, but some very simple education and modification really, it took away their leaking. And so I think just showing that some of those, treatment options can be very helpful before we use long wait times and consider surgeries, right?
And the other thing, just to add to the benefit of pelvic floor physiotherapy, is that a lot of the older women that come with leakage have both stress or incontinence, so leakage with cough, sneeze, exercise, but they also get overactivity and urgency. And some of them have difficulties emptying their bladder at the same time. So I think it's learning to appreciate it's not only the engaging the pelvic floor muscles, but it's learning how to relax them, which I think is crucial to any of the treatment options that I offer as a surgeon, right?
Yeah. And obviously I've called this episode and I've tailored towards stress incontinence, but very commonly there's a component of overactive bladder with this. And I'll make sure that I link in the show notes. You and I have done an episode before about that. And we talk a lot about the kind of the reflex nature between the bladder, the brain, and the pelvic floor, and how to address that at the same time. Because I think you're right. A lot of this has to do with behaviors we create around our toileting and not understanding how we can make such simple modifications. Can you go into more detail, Jen, then? So, you've done the assessment. So you've used some of your assessment tools and investigations. You've recommended pelvic health physiotherapy. And I'm going to have actually an episode with a gynecologist about pessary fitting, but I'm wondering if you can talk about in your practice, between the pessary, and you've mentioned the over-the-counter Impreza, Will you talk a little bit about how that fits in? So do you generally say try physiotherapy, and then do you, in your practice, do you generally suggest that they try the Impreza? And if they like that, you consider a pessary fitting? Will you talk a little bit about how that works in your practice?
That's a great question. So I actually find perhaps I don't emphasize those options as much as I should, because as a surgeon, I usually talk about the surgical options. But I do say, as I told you, there are certain patients that really would benefit from it. So if you're a young woman and you're still planning to have more children and you have leakage only with exercise, you're playing sports, those sorts of things, then the Impress is a great option. And I think that those are the types of women I recommend it for. And for ones that are not interested in having surgery, it's also a good option. In terms of the pessary, I usually recommend it when a patient has pelvic organ prolapse at the same time, because you can get a pessary with a knob that sort of puts extra support on the urethra. And so, I do offer that in my practice if that is something that someone is interested in. Especially in those that have tried pelvic floor physiotherapy and they're still miserable and their quality of life is definitely jeopardized by having this leakage. And so I definitely try those options. But then, I offer also in the same discussion all of the different surgical options that are available.
Before we get to the surgical options, can you talk a little bit about, everybody always wants to know, is there a medication for this? So I want you to talk about that. And I also want you to talk about urethral bulking agents.
That's a great question. So I put the urethral bulking agents in actually my surgical options. In terms of medications for stricture and incontinence, there are some that have been looked at in terms of helping, but with overactive bladder, we've got a handful of medications that have great effect and they have minimal side effects and can be helpful with urgency. But in stricture and incontinence, it's not the same, because if you think about it, the urethra is not strong enough to withstand a large force. So usually we use a physical aspect to improve that ability to withstand this force. There's no medications that can really increase the continence of the urethra or engage the pelvic floor muscles around that area, unfortunately.
Right.
So really, I think of it as, once you've tried the conservative approaches, your dietary changes, the Impreza or the Pessary or pelvic floor physiotherapy, once you've exhausted those options, I usually just recommend moving to surgical interventions, including bulking agents.
Because really, I mean, hormones don't really fit into a medication, but hormones basically, I always explain that they'll kind of beef up your tissues and they make it easier kind of for the pelvic floor muscles to close the urethra. Essentially, all the tissues are better able to close the urethra, right? Provide sphincter control.
Right. So vaginal estrogen, or if you have a history of breast cancer or cervical cancer, something like a hyaluronic vaginal application can be helpful, especially in helping if you have vaginal dryness at the same time. But it isn't necessarily evidence-based to treat the stricture incontinence, but it's also minimal harm. So we often use that. And then in terms of other options, besides the vaginal estrogen, there's really no good medications that can engage the urethra in that way.
So will you explain urethral bulking agents?
Right. So when I talk to women about surgical options for stress and incontinence, I go into that there's different slings, and I'll talk about those later. But I also mentioned urethral bulking agents. So urethral bulking agents is injecting an agent that should stay and increase the size of the urethra to prevent you from having the leakage. The good thing about this is that it's a minimally invasive procedure, but you do need an anesthetic. The bad thing about this is that you need to have it done more than once. It's not something that lasts a long time. And then in terms of efficacy, it's not as good efficacy as the slings that are available. Okay. So with the bulking agent, you do have an anesthetic, and I basically inject with a small needle in different areas of the urethra to enlarge it, to prevent you from having leakage. But in terms of overall efficacy, some studies quote 50%, some studies quote 70%, and that's in patient satisfaction. And you would get it probably once a year afterwards.
What is it? What are you injecting, Jen? Sorry.
Yeah, so there's different types of agents you can inject. There's Bulkamid, and in Kelowna we use Deflux because that's what we have access to. And these agents are great because they stay within the urethra and bulk it, but they don't go other places and migrate other places in your body. So they stay really focused in the urethra. So those are the types of options that we have for urethral bulking agents. And to be honest, I think it's a very select patient population that I recommend it for. For example, elderly women that have very, very severe incontinence that really aren't good candidates for larger surgical approaches. And also women that have already had slings and have continual leakage. This is definitely an option that I offer them because we know it's temporary, but at the same time, you know that if someone can't pee when they have it done because it's too much bulking, then that will wear off over time.
What about some of the other surgical options?
So we have in our repertoire 3 different types of options for surgery. One is using a small piece of mesh that goes under the urethra. Okay, and that's called a transvaginal tape or transobturator tape, depending on how it's put in. Another option is called the Birch colpo suspension. So if you're having your uterus removed laparoscopically or with tiny ports, then the Birch colpo suspension is definitely a great option where you basically just bring support to the urethra from inside the abdomen. And then the third option is called the pubovaginal sling. And that's where you take a piece of fascia from the leg or from the abdominal fascia, and you put that underneath the urethra. And there's definitely pros and cons of doing any of these techniques. One thing I would like to mention though, is that, you know, when I do these surgeries for men, I quote success rates of 80% at 2 to 10 years, which is wonderful, right? But with leakage in women, the success rates aren't as good. So even with perfectly done transvaginal tape, it's about 70% chance of being happy with the result 1 year out. So I think that's important to keep into context, that it's not a perfect treatment for women, but it is a good treatment if it helps you get back to doing things like exercise, those sorts of things.
So how would you choose? I mean, obviously you're looking at the person in front of you and there's always so many things to consider, but how do you choose one option over the other?
It's a very good question, and I think it all depends on the degree of bother for the woman that's in front of you. And then I like to spend time to talk about the pros and cons of each of these. So with the Birch colpo suspension, I think that's really reserved for women that are having concomitant or surgery at the same time, having their uterus taken out. So that's definitely something that I would suggest is for them. And the outcomes aren't as good as the 2 other types of slings overall. So I don't often do the Birch colpo suspension. In terms of whether or not the transvaginal tape with mesh or transobturator tape with mesh versus the pubovaginal sling, I think it comes down to they are equivalent in terms of patient satisfaction, which is 70% at 1 year. But you really have to think about this because there's an FDA warning against FDA and a Canadian Health Canada warning against the use of mesh in what pelvic organ prolapse surgery. And so the mesh that's used in the transvaginal tapes, transobturator tapes, has had a very bad rap as a result because it's followed a long suit, but it's a much smaller piece of mesh. And we have guidelines in Canada and the US that say that it is a safe option for women. But the caveat is that 3% of women may have a little piece of mesh that erodes to the vaginal wall, and that can lead to pain, and it can be chronic pain, and it can lead to pain in the spouse as well. But you have to, during intercourse, but you have to recognize that this mesh is 7% of the time is very good, and you don't have that associated pain. So that's a very important point when you're thinking of using mesh. And if someone feels strongly that they would never want that to happen, then I definitely move more to the pubovaginal sling using the fascia from the abdomen. But the pubovaginal sling is a bigger surgery because you're doing an incision into the abdomen to get the fascia, and there's risks associated with that. And in, the past time, we used to use the fascia sling more in women that have already had a mesh sling and they still have leakage. But I think they're equivalent options that are available for women, and they both do work fairly well for women if it's done for the right reasons. So they're both on the table. And it's really a discussion between the gynecologist or urologist and the patient as to what is best for that specific patient.
And so do you tend to recommend, so obviously one of the downsides to seeing a pelvic health physiotherapist is that our healthcare system doesn't cover the cost. I mean, if you don't have extended medical coverage, you generally pay out of pocket. So I get that that's one of the downsides. But what do you find then that almost everyone, because I get that you're looking at the person in front of you and you're looking at the bothersome rating that they have, you're looking at their quality of life, but do you find that pelvic health physiotherapy goes with that recommendation, whether they're choosing to have surgery or not?
I'm actually part of the Canadian urology guidelines on stress incontinence right now. And I think a big fundamental part of it is that pelvic floor physiotherapy is your best bang for your buck, even if it is quite expensive. And I think it can really help the majority of women with leakage. So I always would prefer, if possible, that a patient tries that avenue of care before moving towards surgical interventions. I think I'm a surgeon. I like to operate, but there's a higher risk associated with having surgery, of having complications and those sorts of things. So if we can, it would be great to be able to, all women with stress incontinence, to try pelvic floor physiotherapy first, if possible. And we are doing some studies in collaboration, yourself and some of the other pelvic floor physiotherapists across the area, looking at, for example, if there's a role of virtual pelvic floor physiotherapy, to see if there's any role for that, because perhaps that's a less expensive, more accessible option for people. It's a research study, so we don't know the answer to that. But I think if we can find options for women that don't that allow for them to have better access to care in terms of pelvic floor physiotherapy, I think that's a great option for them moving forward.
Yeah, I mean, I definitely would say, I mean, I see lots of people through online appointment across the province or anywhere in the world. And I definitely say, I mean, that's not data. This is just anecdotal information, but I see all the time, just by educating people about what the system, how it works and how the pelvic floor can help with continence and strategies for when you lift or when you cough or when you sneeze, that, just change the things that you do. I see it all the time, how helpful it is. So I look forward to seeing what the results of that are. But I do think that sometimes there's a misunderstanding about what we do have to offer, and people have heard that all it is Kegels, but there's so much more to it. And I can't suggest enough to listen to the episode that comes before ours here, just to get a little bit more of an idea. And I couldn't help I want to go back to some of the research you're conducting at the end, to make sure that we kind of try to collect some subjects to help gather some of this data. But really quickly, one of the things before we go, Adrian and I were talking in the last episode just about the NICE guidelines that England puts out, and they're evidence-based recommendations for healthcare. And I can't help but think, I mean, our system is very much a reactive system in so many ways. I mean, when issues come up, we treat them, but you do see some of the recommendations they have just around, considering the pelvic floor in the syllabus for midwives, training nurses, doctors. I think that that's a missing piece, and just learning a little bit more, because there's such high quality evidence for it, but just learning as women go through changes in their body, puberty, having children, aging, just learning a little bit more about our bodies and how we can be proactive so that we're not always chasing these issues. And I wonder, like, do you see that? Is that changing in some of the education syllabus and in the training? And yeah, will you speak to that a little bit?
I think that's a great point. The NICE guidelines are very good and they're very evidence-based, and they really look at doing systematic data reviews to back up what they're recommending. And I think, yes, pelvic floor physiotherapy is a key aspect of that. And when we think about how much education did I have in my residency training and my medical school training with pelvic floor physiotherapy, I had zero training unless I sought out to look for that. And I think that reflects the importance of us getting together as a group and collaborating and actually working together to help each patient find what's best for them. In terms of syllabus training, for example, like I am trying to build a program in female urology. And one of the mandates of the program that I'm trying to build is teaching future physicians, pelvic floor physiotherapists, nurses, about this subject area and collaborating in that regard. I think moving forward, if we can find people that are fully interested in this field and can actually prosper and actually provide care, it can only benefit patients more. And so I think, we don't have the established background right now in our curriculum, that sort of thing, but I am definitely trying to move that forward. And I already have a handful of keen medical students that are already interested in this. And I'm hoping that those are the types of people that will go into this field.
Well, I see that because, I mean, if you look at, for example, things like these evidence-based guidelines, like the ICS guidelines, you mentioned the Canadian Urology guidelines, the NICE guidelines, any of them. I mean, because those lay out evidence-based guidelines and suggest pelvic health physiotherapy as a first line. Why do you think, is that just fit along the same line as that it takes X number of years for research to make it to clinical practice? Is that all, like, because I'm guessing that the syllabus is based on evidence-based guidelines. So I guess I wonder, why is that missing? Is it just the time, it takes time to change things?
I think it is that. I think it's as a surgeon, I've definitely learned how to do the appropriate surgeries for stress or incontinence, how to do the pubovaginal sling, the transvaginal, transobturator tapes, but we haven't spent that much time. There's just a lot to cover in the medical curriculum, particularly in medical school, to cover every type of medicine that's required. But I do know that I trained at University of Toronto, and one of the things that they really focused on was collaborative care. And so we did sessions with physiotherapists, occupational therapists, nurse, as well as naturopaths, homeopaths. And we really tried to work through cases together, problem-based learning. And I think that the way the medical schools are trying to address this gap, this lack of awareness, is to really foster the collaborations with each other in our disciplines. So it's not necessarily that I go and learn how to do pelvic floor physiotherapy, but for me to recognize those people that will benefit it and then have a conversation with someone like yourself to actually get access for each patient to that care. And I think that's probably a good way to go.
And so I think, like, if I kind of connect some of the dots that we've talked about, if you're talking to, people that are listening, and I'm sure they're listening, not only maybe their care provider that works with people that do have stress incontinence, or someone that has stress incontinence themselves, and they're interested in accessing your services and your expertise to do an assessment and a treatment plan, your recommendation would be, while you wait, ask your GP to look into some of the things that are recommended first line. Like, can you take a look at my vulvar tissue? Would I benefit from some estrogen therapy? Would you do some testing to see if there's anything else they have access to? See a pelvic health physiotherapist and exhaust those options while you wait to see me. Would you say that is your recommendation for people listening?
Exactly. I think that's well articulated, and I think that's the best approach you can have.
So then, if we kind of tie it up with, we want people listening to be involved in some of the research that you are conducting. Now, you did your PhD before you got into medical school. Is that correct?
That's right. So
yes.
I did did it in prostate cancer biology, but obviously I've changed fields, and my passion and my focus is really in women's health now.
Because I have just absolutely loved when I get an email from you saying, I have a medical student that's going to look into this and I would love to involve pelvic health physiotherapy. It always makes me feel so happy. But obviously, research can't happen without subjects, because you need to have subjects to be able to study, to be able to make recommendations. And I think it seems that it's hard to recruit subjects. And so I would love for you to take some time and explain some of the things that you are looking at right now with the medical students. Who are you looking for as far as subjects? And I'll make sure that I provide some links in the show notes that allow them to reach out to who, the avenue that's most beneficial. But will you talk about that, Jen? Who are you looking for?
Right. So at this current time, I think we'll expand our program as we go, but I have 3 studies that we've sort of thought about recruiting patients or participants to. And really, we're asking people to give up their time, probably about an hour total of their time. And I think it's really important to note that it can help lots and lots of women out there with these issues. So the first study we're looking at is comparing virtual versus online versus in-person pelvic floor physiotherapy to see if it actually works for women with stricture incontinence predominance. And so that's one of the first studies that we're hoping to recruit. And it's basically you do one of those types of treatments and you can answer questions along the way, and we can compare the results to see if these avenues are good for women. Another study we're looking at is in overactive bladder, which is not the focus of today's discussion, but I'm interested because one of the medications can help improve the size of your bladder and reduce your urgency. There are so many women that say they're looking for a bathroom along the way when they're exercising because they can't get their full workout in before they have to go pee. So my hypothesis is that with a medication that treats overactive bladder, perhaps that will improve someone's ability to exercise. And so we're looking at that. And that's another questionnaire-based study, about an hour of time. And the last one is looking at, as you alluded to with vaginal estrogen, the effects on dyspareunia or burning or pain with intercourse, and the vaginal dryness or genitourinary syndrome of menopause. And we're looking at the role of pelvic floor physiotherapy in treating that, because I don't think it's really answered a lot of the besides pelvic floor physiotherapy in stricture incontinence specifically. Pelvic floor physiotherapy can be applied to many of the challenges women have with their bladder and their vulvar area, but we don't really have good evidence to support that. So that's the plan in terms of those types of studies as we move forward. And we really appreciate when people spend time volunteering. We know people are busy, but it might help other women with these issues down the road. And now all of this research is within the context of me trying to collaborate with people like yourself, as well as the nurses at Kelowna General Hospital, really to bring a female urology program in place, because, we're struggling to have urodynamics accessibility and Pessary fitting, all these sorts of things. And if we can have it under one umbrella, I think it would be great for women in the interior health region.
You are doing amazing things. And I know this, this is, I'm sure, a lot of, sleepless nights and extra work that you put in. So thank you on behalf of, so many women out there for everything you do.
Oh, my pleasure. And I'm happy to see women that are struggling with this. I think one thing we should keep in context is that, it all depends on your degree of bother. You might even have a little tiny amount of leakage, but it's quite bothersome to your overall daily activities. Or you might have significant leakage and not care that you wear pads. And so whatever you choose in your journey in terms of management strategy should really be reflected in that, how bad it's affecting your quality of life.
Absolutely.